Happy to have you with us after the summer break. And we are back with a very interesting topic. Tonight's topic is going to be non-surgical management of endometriosis with practical tips and tricks. Our guest tonight, our speaker is Dr. Guri.Majak from Norway. Moderator is going to be Professor Mohamed M.Mabrouk. He's the EEL president, newly elected in June 2024. Before starting, we'd like to thank again our sponsor, Gedeon Richter, and for that, please allow me to share with you a short video, and then we can start with the presentation.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gedeon Richter. Health is our mission.
Thank you for your attention. Mohamed, you have the floor as moderator this evening and as EEL president, so we can get going.
Well, thank you very much, Shalim. Thanks for our colleagues who are joining us after the summer holiday. Thanks to Guri. We know that endometriosis is a disease that is not very easy to manage. It is a disease where we have to be patient-oriented. Patient decision should be taken in consideration. It's not lesion-oriented. We have to consider so many factors, and this is why, yes, we do surgery for endometriosis, but in so many cases, non-surgical management is absolutely needed. I have attended a similar lecture from Guri before, and I found it absolutely interesting, and I learned a lot from the tips and tricks that she gives. So I would like to declare that this is a conflict-free presentation. No one of the speakers or the moderators have received any financial support for this presentation. We're happy to be here with you. Guri, please. The floor is yours.
Thank you. Now I will see if I can share my screen completely. Hopefully, just a second, and I will introduce myself properly to those that do not know me. Just there we go. Yes. So, yes,
Perfect.
My name is Guri.Majak. Yes, thank you. So my name is Guri.Majak, and I'm a senior consultant at Oslo University Hospital in Norway. Norway is a small country, but we do at our department have a large volume of patients with endometriosis. I'm first and foremost an endometriosis surgeon, and we do around 1,000 surgeries per year for endometriosis and adenomyosis. Including all types of multidisciplinary surgery. We also have a really appreciated and tight connection with the pain clinic at our hospital. I'm also the head of the newly established National Advisory Board for endometriosis and adenomyosis, together with some of my really esteemed colleagues. On behalf of the government, we are set to increase the knowledge and competence of endometriosis and adenomyosis in Norway over the next 10 years, and I'm really looking forward to that work. Now, before we start, I want to make two disclaimers. The first one is that this topic is huge, and we have 30 minutes. So I really look forward to the discussion later and experience sharing with you all. Second, I'm a surgeon at heart, and today's topic is not about surgery, everything but surgery. but I just want to start by saying that I think that well-planned and well-performed surgery is at the core of many, if not every, patient with the debilitating symptoms from endometriosis as a part of a plan towards a better life. So just bear that in mind as well, since we will not be talking that much about surgery today. Now, to set the tone about today's really important topic, I'll let this patient speak first.
Can we just talk about the grief that comes with being diagnosed with endometriosis and the grief that comes after it returns? I don't know how doctors expect us to just accept that it has no cure. It's a difficult thing to be in peace with, and I know that it has no cure, but I had my surgery 10 months ago now, and a part of me thought that I have my life back and that I'm fine now.
So sorry, I think the video froze a little bit, but the message I hope was clear. And if we read the publications, this is a situation that a lot of our patients are in. 20 to 40% have persisting debilitating symptoms despite surgery or ongoing medical treatment. And I think this is something we need to discuss, and that is what we are going to do today. I guess you've heard the notion that it takes a village to grow a child, but it definitely also takes a village to grow endometriosis tissue. And this is where we will start today with this simplistic drawing, just to set the tone for what we will aim for when we start treating. So this drawing is quite simple, but I think it contains really the most important things when it comes to endometriotic lesions. And at the left down bottom corner, you see the fuel, estrogen. And the endometriotic lesions are kind of like self-sufficient factories, feeding themselves on estrogen and making their own estrogen. And this is a really important point. Estrogen is like the anabolic steroid for endometriotic tissue. And knowing that it is able to make its estrogen production itself, of course, related on vessels and blood supply that gives the substrates for building the hormone, it can be self-sufficient. Converting androgens to estrogens using an increased amount of aromatase, and it's also changing the type of receptors needed, meaning, receptors are like keyholes, and when the hormone attached, it unlocks functions and events happening in the tissue. And the beta receptor for estrogen unlocks inflammation. It unlocks proliferation, as opposed to the alpha receptor that is more calm and anti-inflammatory. So this is the receptor that the endometriotic tissue wants. It also increases the level of the enzyme called COX-2, which we all know when we treat the patients with NSAIDs, which we will talk a lot more about on the next slide. And this again increases the level of prostaglandins, which again increases the aromatase activity and the increased level of estrogen. So like this, it goes like a circle, being self-sufficient. So the prostaglandins are lipid compounds that are floating around in the whole body like hormones, meaning we all know that endometriosis is a chronic inflammatory systemic disease giving systemic symptoms, and prostaglandins are at least a part of the explanation for some of the systemic symptoms you can experience as a patient. We know prostaglandins are highly contributing to dysmenorrhea, muscle contractions in the uterus, vasoconstriction and shedding of the endometrial lining. We know that we can measure the level of prostaglandins in adolescents with a lot of pain. They have more, but prostaglandins also, for instance, reduce absorption, and increases the water in the gastrointestinal tracts, giving bloating, which is a really bothersome symptoms for a lot of our patients. It can act on the thermoregulatory center of the hypothalamus in the brain, giving a feeling of fever and sickness. It's highly contributing to migraine attacks and debilitating headaches. So prostaglandins are really one of the things that we want to inhibit and combat when we try to combat and manage symptoms with endometriosis. And there are then the COX-2 enzyme and the COX-1, which acts quite similarly, that are the things that we want to reach with the NSAIDs, which I guess all of you prescribe your patients. There are a lot of different types of NSAIDs. There are fast-acting, long-acting, and to start with, my first practical tips is to give your patient a prescription of different types. So give the fast-acting ones and also the long-acting ones, like ibuprofen and diclofenac, for instance. It's named differently in different countries. And then let your patient try. Maybe some of the fast-acting agents are more likely to give effect if there is a really pain exacerbation, and the slow-acting ones more for the regular days with the slow, steady state pain. Let your patient choose and find out what is most suitable. And if there are some gastrointestinal problems with the COX-1, which is the cheaper one, the ones you can buy without prescription in most countries, then of course you are free to try the COX-2 ones as well. Try and see and also give instructions to the patients. At least many of my patients, they feel bad when they need to take painkillers. They delay, think maybe they don't need to take as much, maybe they can go with a little bit less. So at least try and make some instructions for your patient. How much can they use? What is maximum dosage? How should they proceed when they take, so that you relieve the patient from some of the responsibility and make her more pain-free, which is really important when it comes to trying to minimize the risk of chronic pain, which we will talk more about. The omega-3 fatty acids are also shown to reduce the levels of prostaglandins and cytokines as well. And it's also shown in animal studies that it reduces endometriotic lesions size. But as we all know, mice do not have menses, and therefore these results are not directly referable to humans, and we need more good studies, RCTs, on humans before we can give direct recommendation regarding the omega-3 fatty acids. But as we know, omega-3 is good for the brain, for the body, so it's not something that is that you can take it anyway, but maybe it also helps when it comes to the inflammation and the prostaglandins in the endometriotic lesions. Yes, we talked a lot about estrogen, and we will talk much more about estrogen because this is the fuel where you upgrade the beta receptors, increasing inflammation, proliferation, neoangiogenesis. The apoptosis, of course, is reduced. This tissue do not want to die. It wants to have estradiol, not estrone, which is the less potent estrogen we have. And at the same time, the progesterone receptors are often working differently or not working at all. This is what is known as progesterone resistance, meaning that if you have a patient on hormonal therapy and she's not responding, or she has responded and then stopped responding, this might be the reason. And quickly explained, it is most likely the inflammation that changes the gene expression and also changes the mRNA, giving a different look of the progesterone receptor and making it not work as well as it should. So the progesterone hormone has no place to lock itself and unlock its the good functions that we theoretically think it has in the endometriotic tissue. So for the future, we really wish for what is named a super cool name, intracrinology, to attack the hormonal function in the tissue itself, meaning that we do not go through the whole system and the blood supply. We want to aim for the specific mechanisms in the endometriotic tissue to stop the increased production of estrogen, the changes in the progesterone receptors. And if this seems like science far-fetched, it's not. It's actually science ongoing at full speed this moment. And I hope that we will have some really cool results in the really nearby future. So just to make you a little bit more curious, yes. So this is a video, and I hope maybe this is functioning. No, it's hacked. Yeah, okay. I hope that when you see your patients in your daily work, that you sometimes pause and let yourself be a little bit amazed about how different expression this disease has in different patients. This is a young patient, and as we see, these are vesicles, new vessels also, neoangiogenesis. And when I first saw this, I immediately thought that this looked a lot like an allergic reaction. And it sure does. And it has a lot of mast cells, which are also known to be an important part of allergic reactions. And these mast cells, have estrogen receptors and corticosteroid receptors on it. And the level and amount of mast cells are really correlated to the level of pain in the patient. So what if we could inhibit these mast cells as well? If someone wants to make up some local treatment for that, please be my guest. It's possible. Yes. So the one thing that we have not, the one thing we have not addressed, I think, sufficiently when it comes to this group of patients is the anti-inflammatory treatment. And here we can also think that we can use already approved treatment for other diseases like CGRP, which is calcitonin gene-related peptide. Inhibitors of CGRP are revolutionary when it comes to migraine treatment. And yes, guess what? The CGRP is also present in endometriotic tissues and lesions. The substance P, neuroinflammatory agent, the endocannabinoid system, which is our body's pain relieving system. Maybe we could stop the supply of substrates and blood and fuel to the endometriotic lesion through anti-angiogenesis medications. Yes, if you want to read more, please read the article by Saunders and Horn in the Cell. It's a perfect publication, maybe a little bit heavy to read, but it contains a lot. And if you haven't read it, it's highly recommendable for also for some positivism against future treatments. Yes, now we will move on to a more practical part, and we will talk a little bit more about hormones. And of course, we have a toolbox of hormonal therapy that is large, containing a lot of different types. And the question is always what to choose. Now, we know that estrogen is pro-inflammatory. Progesterone or progesterone is thought of as anti-inflammatory, meaning that in theory, progesterone or progestins as monotherapy would be a better choice. But we also know that that gives often bothersome spotting and intermittent bleeding for the patient. The side effects, at least if you add a more hypoestrogenic state with a high dose progestin-only medications, can be intolerable. So yeah, you will pick and choose. Of course, contradictions to combined oral contraceptives leaves combined oral contraceptive out of the question. But otherwise, if you will use a combined oral contraceptive, you will choose your progestin well, as you will see in a slide soon, and you will use it continuously. This is a really good Cochrane analysis that shows that this is really safe. For the progestin only, please also have tools for when your patient feels that the bleeding is too much. And increase to a high dose if you feel that you do not have the sufficient effect. Now, we do know that the progestin-only therapy, even purely dienogest, can affect the bone mineral density in our patients. And this is important because we often have young patients, and the bone mineral density is a bank that is built in the adolescence into the 20s. And this is the bank that you use for the rest of your life. Meaning that if you do not build your bank sufficiently, you will have a greater risk for osteoporosis when you get older. So this is important, so important that this has been discussed. This is more an expert opinion publication from Bersolini, but I think it's an interesting topic because the ethinyl estradiol that is used in most oral contraceptives is really a supraphysiological amount of estrogen, meaning that you give a lot. Maybe you should try to give the lowest dose. Maybe it's, and hopefully, I think it's rational to think that the new types of estrogen that are in combined oral contraceptives like estetrol or estradiol valerate might be a little bit better. But if you choose a progestin only like dienogest or drospirenol, and you're afraid of the bone mineral density because you have a young patient, then maybe estradiol, small dosages add back is a good choice. And when we look at the studies for what amount of estradiol is needed to protect the bone, it's as low as 25 micrograms. So between 25 and 50, like with a patch or gel, I think this is maybe a new way of looking at lowering the amount of estrogen and still give progestins for the patients that need it and have sufficient effect of it. So this is also something that when we discuss, of course, the hormonal regulation of the menstrual cycle, to see if that is something that can be helpful in management of the symptoms. We really aim for an ovulation and amenorrhea, and always. Why? Because we do know that iron, retrograde menstruation is like a general phenomenon. But for patients with endometriosis, the iron is really toxic. It's making a really inflammatory environment, a lot of oxidative stress, and we now have a lot more than one publication showing that iron will, in endometriotic lesion, be able to turn on some cancer-like mutations known as CRAS, which turn on the ability for the endometriotic lesion to go into deep endometriosis, going into neighboring tissue. So by steadily flowing iron into the endometriotic lesions, we will make everything potentially much worse for our patient. That's why the amenorrhea is so highlighted here. And this is just to show you the degree of amenorrhea on progestin only, so that we have a realistic expectation of what we are trying to achieve. These are the Norwegian names. If you want to ask me about what the progestin names are, please do so afterwards. But just to show you that the higher dose of progestin, the more amenorrhea we will have. But then again, you need to think about the bone mineral density and the hypoestrogenic state that you're putting your patient in. So this is also just to give you a a list of the different progestins and the different variants we have that we can play with. And also, of course, if you want to treat something like PMS, acne, hirsutism, you can, of course, choose also according to that. Now, Dianogest is probably the one that is most studied when it comes to endometriosis and has been shown to have some quite, it's really good compared to GnRH analogs, and it's also showing some anti-proliferative, and it has something when it comes to the endometriotic lesions that we think is good. But that being said, these progestins are not measured against each other, so we really don't know. It's more about looking at the risk factors like thrombosis and what are the things the patients are struggling with. And again, I think this is probably something that just needs to be said. I think everyone know, not everyone thrive on hormonal therapy, meaning that the side effects can be intolerable for some of our patients, meaning that sometimes you need to change because you might have some effect on the pain, but you do not have side effects that are tolerable, and you may need to change to something else. But for other patients, it's non-negotiable, and they do not want to be on hormonal therapy, and that is, of course, fully acceptable, and just you need to just have a broader plan for management of her symptoms, so that this is not something that she, you need to have a broader plan, which we will talk more about. Yes, just quickly about the GnRH agonists and antagonists, because we are now having antagonists on the Norwegian market as well. And these have some advantages, being oral, meaning that you can discontinue the use and immediately, and you can avoid the flare-up. The GnRH agonists and antagonists are really last resort. When you have tried and not succeeded with, of course, well-planned and performed surgery, other medical treatments, and the patient, and you really want to know if the hypoestrogenic state will reduce the patient's pain. This is something that can be tested for a short period of time, but it needs to be in expert hands, and it needs to be with really proper guidance of the patients, just that being said. And you need to, of course, be aware of DEXA scans, D vitamin and calcium, and the patient's mental and physical well-being. Just to make sure that you all remember, if you want to do the add back on the agonists, that you remember Tibolone, which is a medication that also increases the testosterone a little bit. That can also be a good option for the patients as an add back. So I will now talk a little bit about the ovaries, which are also a favorite organ. And I'm really happy that we are now increasingly aware of the ovarian reserve and how this is decreased in almost all patients by the endometriosis disease itself, and how we need to take really good care of the ovaries, meaning that surgery is not always the best choice. So repeated surgery on ovaries, we know, is reducing the capacity a lot. And for some small ovaries with no symptoms and no signs of deep endometriosis, dyspareunia, etc., it's good to have also this meta-analysis and systematic review that shows that both the diameter and also the volume is shown in the same publication is decreased by different types of medical management. So this is also something to be aware of when you discuss the risk factors for together with your patient. The recurrence of symptoms here in this publication, it was measured radiologically and also symptomatic, and this is a systematic review containing a lot of publication and showing that the risk of recurrence symptomatically or radiologically was a little bit lower in those having postoperative hormonal suppression. With this was both combined oral contraceptives, it was the Mirena coil, GnRH analogs, different types of hormonal suppression. And just a quick notion that we have a lot of studies in the field of endometriosis. That means that when we put them all together, it can be sit in, sit out, meaning that if you don't have control of the bias in the study, how the surgery was performed, etc., etc., it will also affect the result that you see in the end. So yeah, just bear that in mind, but I'm really good and happy that we have some systematic reviews and meta-analysis that puts all these results together. Yes. Now, just a quick to end the hormonal discussion, we will talk 2 seconds about the peri and postmenopause, because yes, patients with endometriosis can also have postmenopausal or perimenopausal issues. And we do aim for, this is a really nice publication, by the way, from Sweden. It's more of an expert opinion because in this area there is definitely not much evidence, but we do think that as long as we think that combined oral contraceptives should be given continuously, then postmenopausal hormone therapy should also be given continuously. We do not have studies to show that this is better, but still, we aim for the lowest dose estradiol that controls the symptoms. Yeah, consider the small increased risk of breast cancer depending on what type of medication you're choosing. And of course, the fibrosis, adhesions, etc., that endometriosis has given through the years could definitely need surgery also postmenopausally. And the recurrence of symptoms in a postmenopausal woman, meaning that she has been well and then gets sick again, needs definitely a good evaluation. The same, of course, with keeping an eye on the endometriomas, but this is a different subject. Yes. Okay. I have to talk a little bit about pelvic nerves. This is a lecture of its own, but just a quick word. Yes. So this is not just a fantastic photo. It's endometriosis cells, the blue ones, and the red lines are nerves, new nerves. And the neoneurogenesis in endometriosis is probably one of the lead reasons for the peripheral sensitization that we see, meaning that you have an increased hyperalgesia and increased perception of pain from neighboring organs to the endometriosis, which in case also if it is standing for a long time can give a central sensitization where you have an ongoing situation with more chronic pain. Now, I would not talk a lot about surgery, but you need to see this because repeat surgery is, I think, a little bit of a problem. And as we see here, just had a screenshot of this paper that shows the increased amount of neuropathic pain following repeated surgeries. So well-planned surgeries is really essential. Having a notion about the pelvic nerves, where they run, what kind of symptoms they give, how to do a clinical examination, and what kind of symptoms the patient usually has is, I think, mandatory if you have patients with a lot of pain. And some of the neuropathic pain is treated surgically, of course, but definitely not most. But you just need to know what you are up against and what the reason for the pain is. So this is just an example. The pudendal neuralgia is really easy to examine when you have a gynecological examination. The treatment can be really efficient. This is our way. I know there is no European guidelines or consensus, but this is we do this quite a lot and have quite a lot of experience, and we do have a good experience with this, and we can discuss this also further just when I'm done. The neuroleptica for neuropathic pain. I think we often leave that to the pain clinic, and I think the results are often suboptimal, having a lot of side effects. But yeah, it's something to be discussed in the pain management plan for patients with severe pain. I think also we need to discuss a little bit more in the future about the cannabinoids. I know that when we ask, a lot of patients self-medicate. And we do know that there are medical CBD, for instance, or other medications. I think we need to have more evidence-based results for what this can do for the patients with the most severe chronic pain and spastic musculature in the pelvis. Yes. There is emerging evidence for the use of physiotherapy for endometriosis patients. And for me, it's kind of mandatory that a physical therapist is a part of the multidisciplinary team around management of endometriosis-associated symptoms. And hopefully now we will have more and more evidence also. Because we know that a lot happens to the pelvic floor musculature, and we know that it's hard to differentiate between somatic and visceral pain in the pelvis, and that a lot of patients really benefits from proper physical therapy. And what we know is that the impact of exercise on the perception of pain is not that good, meaning, of course, exercise and physical activity is necessary and needed for cardiovascular health and well-being, everything, but it's not something that you prescribe for treatment for endometriosis. The psychological and mind-based therapy appears promising, probably because they connect the patient to the parasympathetic part of the autonomic nervous system. A body with endometriosis is under a lot of stress, and it's often really sympathetically driven. And to connect to the parasympathetic rest and digest system is also good for these patients. Of course, the pelvic floor therapy is beneficial, and also the use of TENS. Yeah. Now, I will end this talk with a little bit of a discussion around inflammation, and just a reminder that endometriosis is a chronic inflammatory disease. We know that inflammation also occurs from loneliness. The brain is a black box, and even loneliness creates the same physical response as other types of stress. It's more severe than smoking, actually. And everything around this is something that I think we need to have more future attention to. That does not mean that endometriosis is a lifestyle disease, not at all. And our patients are really, really striving to do the best they can to achieve better symptom control and to make them eat better, perform better with physical exercise, etc., is maybe also just contributing to stress. So I'm at least really, really careful with doing that. That being said, I think we need to end this with talking a little bit about the gut, because there is a lot of exciting emerging evidence when it comes to the gut microbiota and the microbiota in the genitalia interna and endometriosis. And we know that the gut is the main distributor of you know, when the estrogen goes through the liver and is supposed to go out with the stools, with the bowel movements, some types of bacteria are able to throw the estrogen back again. It's called the estrobolome, and means that this is some way of controlling a high estrogen state that might be harmful for patients with endometriosis. We know that the gut microbiome is really connected to the immune response and the inflammatory response in the body, and of course all of our important neuromodulators in the brain, dopamine, serotonin, are made in the bowel. So the gut microbiota is really important, and I think we will see an emerging a lot of new research regarding this in the future. Okay, so this is just my last tips and tricks. This is what we created at our clinic. We felt that we had too little time at the outpatient clinic. We felt that we had much information on repeat for each patient. We felt that we lacked the psychological support and the physical therapy close to us. So we gathered all this in a patient and relative course, included physical therapy, stress management, mental coach, and a psychologist. And that this has been a really good success, reaching out to 40 patients per course. It's over 2 nights, 3 hours per night. And this is also something that I think has been a huge success. Okay, I think this was it. Yeah, it was. Yeah. Thank you so much. Now I warmly welcome all questions and inputs. Thank you.
Well, thank you very much, Guri. Extremely interesting and very comprehensive, as I was sure it would be. And I have some questions here, very interesting questions as well. So I just would like to emphasize, if you permit me to, that the title is non-surgical, but the reality is it's not surgical or non-surgical. It's the integration between, as you perfectly said, between the two things. It is a surgery with so many other things that help the patient to have a better quality of life, better improvement of her pain, and achievement of her objectives, whatever these objectives are, fertility, pain management, and so forth. So thank you very much. We learned a lot, and I have so many questions, but I can see here that our colleagues, the audience, have a lot of questions as well. So let's start with our colleagues. So I have a question here about how long the energies can be used for. So because you spoke about bone mineral density, and you spoke about safety profiles in long-term use. So the question is, yes, please.
Yes. So I think that you can choose to use Dianogest as a combined version, of course, as a combined oral contraceptive pill, and then you do not have to be concerned. If you use Dianogest only, I think the studies have measured the bone mineral density that is decreasing by 1% in 6 months. I think it was that was the study. So it's not much, but over the years, it's also maybe affecting the building of the bone mineral bank. So I think if you have an amenorrheic patient on Dianogest, I think that I would probably add just a little bit of estradiol. Yes, I think that is the way to go.
Irrelevant of the age. So
yes,
yes.
Yes, because it's definitely most important in the adolescents and early 20s for the bone mineral density. But I think that if you make a patient completely amenorrheic using Depo-Provera or something, then you also really should consider that this is putting her in a hypoestrogenic state, and that you might want to give her some add-back. Yeah.
Perfect. So because we are speaking about practical tips and tricks, Guri, if you permit me, I would also confirm some messages that you said perfectly highlighted in your presentation, but I just would like to highlight them a little bit more. Like, for example, the medical treatment. If you start any hormonal treatment, we, as you perfectly mentioned, endometriosis is a disease that we need to evaluate very well. And we see in our clinics patients who have been diagnosed simply with a very small endometrioma. Yes, a small endometrioma, hormonal treatment, but they haven't been properly evaluated. And you find her after 3 years of bombarding with significant hormonal treatments, and then you do an MRI or you do an ultrasound for her, and you find a big, deep nodule, etc., etc. So you agree with me that starting hormonal treatment should be done after very careful, if we can call it staging or imaging or diagnosis or mapping of endometriosis. What's your thought about this?
Yes, I totally agree. And maybe the only group of patients that we need to have a discussion about are the really young adolescents having dysmenorrhea and absenteeism from school. And we do know that a lot of those have a really good effect of regulating the menstrual cycle. And maybe the warning sign is those that do not have an effect and do not have an effect of ibuprofen, etc. They should really fast go for further consideration. But otherwise, yes, it's really important that the diagnostic is properly done, and also the evaluation of the patient's symptoms. Yes.
Great. Another quick question. In this group of patients, because it's one of the questions that I have here, especially this group of patients, young adolescents, practically speaking, short message in a nutshell, what would you start with? Young patient, severe dysmenorrhea, diagnostics, not so much endometriosis, and you counsel the patient, she doesn't want surgery, you will start her with hormonal treatment. You start with the progesterone only, the Dianogest, combined pill with Dianogest inside. What would be your first approach?
Yes, I think probably, and this is just like this, but
Yes.
I would usually start with a combined oral contraceptive to try to get the control over the menstrual cycle. If I would go with a progestin only, I would go with more of a high dose in the beginning, just to stop the cycle and the bleeding, and to have some sort of feeling of what this does with the symptoms. Sometimes also the patients have their own suggestions and wants to try this, and was because they have heard of someone, or it's all about fitting this into what the patient is motivated for trying also, of course.
Sure. But what
yeah,
I also learned today, please, you go.
Yes,
I'm sorry for interrupting.
No, yeah. So, but what I usually do, and this is my subjective preference, is a combined oral contraceptive, and I'll also probably just start with Dianogest or drospirenol. But that's what I usually do.
Perfect. So here, just to in this context, what we are learning from you today also is the 3A approach. And I would highlight it again and remind my colleagues with, it's whatever you agree with the patient upon, but it is the anovulation, amenorrhea, and always. And when you achieve this, you start calculating patients is responding, patients not responding, because if she doesn't have the AAA, maybe we're still trying to find the best hormonal treatment for her. Would you agree with me about this?
Yes, I think that an important point here is that if you have put a patient on hormonal therapy and she's not responding as well as you thought, it might be because she still has her cycle going on if it is a progestin only medication you are putting her on. So it means that she can have cyclical hormonal variation giving her pain and symptoms, and you actually don't know what will happen if you flatten out the cycle more. For other patients, it might be okay to have some part of a cycle. It's not a problem as long as they have, for instance, a Mirena coil that controls their symptoms regarding bleeding and menstrual pain from the uterus. So it's of course a rule that can be, you don't have to follow it all the time, but I think it's just to know that you do not always have an ovulation or amenorrhea on the progestin only, and that might be the reason why you don't have the response you want. Yeah.
Perfect. I am running and I'm speaking very quickly because I have so many questions you cannot imagine. So I will go here with a question. Good evening to everyone. A lot of compliments, and then amazing presentation. Why this is actually an interesting one. Yes, yes. Why are not we treating endometriosis like any other neoplasm, meaning doing surgery, then using or trying, for example, monoclonal antibodies for targeting remaining endometriosis cells or lesions, specifically in patients who already had a hysterectomy? This is, I mean, yes, yes, oncomimetic approach, do antibodies and then see which type of hormones. And the second question that she's asking is if endometriosis lesions produce their own estrogen, what's the point in using progestins at the end to decrease estrogen? Thank you.
Yes. Okay. So I will answer the first question first. I think that the reason why we haven't tested a lot of approved medications that are approved for other diseases is that they have potential lethal or harmful side effects, and this is a benign disease. I think that has been the explanation. And the ethical guidance that has done it impossible to do. Now, I think we will have in the future, like tomorrow, organoids, meaning tissue from the patient that we can do these tests on, meaning that we don't have to send them through the patient. We can test them on the tissue to see whether this endometriotic lesion from this patient responds to this type of treatment. And that, I think, is the personalized treatment for the future. For the question number 2, the progestin does not decrease the estrogen, it just levels the effect. So this is what happens in the endometrial lining during the menstrual cycle as well, where the first part of the cycle is high on estrogen and the endometrial lining grows, and then the progesterone comes, or the progesterone comes and calms it down, decidualize everything. So it's not decreasing the estrogen level, it's just opposing the effect. If that was a good enough answer. Really good questions. Thank you.
Perfect. So back again to a very important concept that you mentioned here, Guri, which is, if I understood well, obviously, it's about progesterone receptors and the impact or the effect of either receptor resistance, progesterone resistance, or lack of response after some time for a reason or another on the mRNA level, etc., etc. Fine. So the question here is, and I'm happy that you mentioned this, that it is not dose dependent at that point. So it's not that we give 20 pills for the patient today and we will obtain a result. And if we increase to 25, maybe we will obtain another result. We have to arrive to a point where we identify that this patient might not be a responder. And I like very much the word. And this is why here our colleagues are asking, what are the tricks if the patient stopped responding to, she's saying or he's saying, asking about the androgens, but we would extend it to progesterone or progestins in general. What are the tricks when the patient stops responding? What would you do?
Yeah, first and foremost, of course, you need to check if there has been actually disease progression. That explains the recurrence of symptoms, that there's something going on that needs different treatment. And if it's not, and if you're sure it's not, then I think you might want to pick out one or all of the other tools that we have mentioned, like physical therapy. Are the pain medications sufficiently? How is her stress levels during her work and family, etc., etc.? It's not an option to increase the progesterone, and I don't think we have really a good recipe for what to do when this happens, but it happens, and it usually happens after some years of good response, and then suddenly the patient comes and she has recurrent symptoms with increasing intensity. So it's a really, really good questions, and I don't have a really, really good answer. But please use all the other tools at least, and of course always check that there is nothing going on that needs, for instance, surgery.
Okay, so again, thanks and compliments. About inflammation, you think being on AIP diet can actually decrease the inflammation in patients with endometriosis and benefit them? Big question. This is the big, long one, but you go.
Yeah, there is no evidence that suggests that. We do have some evidence for patients with endometriosis and IBS symptoms. They respond 3 times better to low food map regimen compared to patients with only IBS and not endometriosis. I am really careful with introducing dietary regimes to these patients because I think they have a lot from before. And of course, because we do not have the sufficient evidence, I'm really careful. If they want to do something, if they are troubled with severe bloating, and many of them are having bowel issues that are really hard to manage, then I would really recommend that they see a nutritional physiologist, is that the correct word? Yeah, someone that can guide and help them try and test diets to see, because you need to register, does this work? If it doesn't work, then quit. Do not put a lot of restrictions on your life and diet for no use, then you will have a really restricted life. Yeah.
Okay. We are running out of time, but I am keen to answer the questions of our colleagues, because I'm sorry, Guri, we can steal 5 or 10 more minutes from your time and from our colleagues' time, but
of course, yes.
Bear with me, be patient. So yes, if patient is young, because now we have created this question mark and we need to address it. If a patient is young and satisfied on diagnosis for a few years, would you consider discontinuation for bone health?
No.
Good.
I would, as I said, I would perhaps, depending on if she bleeds on Dianogest or not, you can also have a look at her estradiol levels, of course. But if she bleeds, it's some correlation with an ongoing partly cycle. But otherwise, put on a little bit of estradiol, and I would be happy. Yeah, and physical activity and vitamin D and everything. Yeah.
Good. So again, the other thing that I like very much today in your talk, Guri, is most of the answer to your questions is it depends, because there is no one size fits all. And you mentioned it, I don't know how many times, it depends also on what the patient wants. So it is so many factors that help and guide our decision-making in the patients with endometriosis. Here, thanks, very nice presentation. Dianogist is there, consensus about bone density. Some studies showed bone loss at 6 months and others did not demonstrate this. What kind of estrogen to add and how this would affect endometriosis? Thanks.
Yeah. So
the point is, yes, obviously you got it. Yes.
Yes. So I think that we do not actually know. And this comes also for the add back with GnRH. Agonist, antagonist, this goes for menopausal therapy. How much estrogen can you give without triggering the endometriotic lesions? And we do not know. But we think that levels below 50 micrograms is okay. But the patient's is the answer. If she has symptoms, she has symptoms, and then you need to go lower. But 25 micrograms is sufficient for increasing bone mineral density, and that's really, really a low dose. So that is, you can go with a patch, or you can go with a gel or a spray, or whatever suits your patient. And the most tablets can come in a 50 micrograms dose. So yeah, and anything goes.
Okay. Here, there is also a question about your thoughts on the small intestinal bacterial overgrowth as a co-condition with endo, and if there's any treatment, and the DEXA scan, something that you would consider in long-term management of patients with the progestin therapy. Sibu first. What?
Yes.
Yes, please.
I think there is much more to the bowel microbiota, including the small bowel, than we know today, also related to endometriosis for sure. So I think we will know much more in hopefully near future. As of now, it's only small studies and hard to draw any firm conclusions. But having a microbiota that is diverse and with the right bacteria and balance is really, I think, yeah, a key for a lot, generally speaking. But I do not know. I haven't drawn any conclusions on SIBO based on what I've read on endometriosis patients for now. The DEXA scans is something of course, when you have an amenorrheic patient for a long time, and it's not amenorrhea on combined oral contraceptives, but it's progestin only or Depo-Provera or GnRH analogs, whatever. If she's amenorrheic, it can also be because of her, energy and health, how much she eats, her weight, everything. So yes, DEXA scans belong to when you want to consider if something is going on with her bone mineral density due to a low estrogen state. Yes.
Sure. Okay. Thanks. Difference in preference progestins and GnRH analogs in young patients. So here the question, and this is again a practical question: how many times would you suggest GnRH agonists to a 22 years old patient?
Oh, I think that's it's not often. I think it's the last part of my line. And after a really thorough discussion with the patient and with a really thorough and thoughtful aim for the treatment. So yeah.
Agreed. So I just, again, if this is the message, I just want, if you permit me, to rephrase it again. GnRH agonists, Zolidec, call it as you want, is not the first line of management in young patients. It is the super last one if we don't find anything else, and thorough counseling and. Good. So here we'll find some questions coming, but I would like to, yes, because this is an interesting question that opens a lot, and maybe to something like 5-6 talks, webinars. Can you diagnose endometriosis by ultrasound?
Yes, it's operator dependent, meaning that you need the skills. I think some types of endometriosis, meaning the large endometriomas, and hopefully also the large infiltrations into the bowel, is something that you should see. The more peritoneal adhesions, lesions, sacrouterine ligament are harder, and you need to be proficient and train a lot, to see. It's possible to see, but you need to train. When it comes to the more superficial, like you saw in the movie, the vesicles and the more superficial changes, I think it's really hard, maybe not possible, and not possible on the MRI either. And it needs the eye to identify and see, and it still needs the surgical management. And yeah.
And here I would take this question to tell that in the EEL, we are very much committed to teach how to diagnose endometriosis by ultrasound. And we have in our teams and our colleagues and our faculty, very, very highly experienced ultrasound gynecologists who do the ultrasound diagnosis of endometriosis with a method. They explain this, and we run very systematic courses. And again, I'm sorry if I have also to advertise for what we are doing in the EEL. We are establishing now a very interactive website where you can go on the website, you learn, you teach, you exchange experience, and also you have some questions, you have some exercises that you can do of recognizing the images of the ultrasound, etc. So this is obviously available for our esteemed members. And, and please visit our website. We are establishing this now. Give us 2 months from today, and you'll be able to explore all this. Guri, I can see here very experienced endometriosis surgeons on Engin Oral, Tanner Usta, and many others. while giving you a lot of thank yous and so many compliments and congratulations. I have to say this as well. And yes, I will, okay, website is, Aline will write for you the website. And obviously, if you just put on Google EEL, please check it and click it, and we will be delighted to have you with us. And last but not least, I would like to, I think I covered, if not all, exactly, Alan sent the link now. If not all, it is 98, if 99% of the questions, but I am aware that it is late now. And I have nothing but thanking you very much for interactive website. Yes. Thanking you very much for the talk, Guri. And if I can summarize all what you said, is it's surgical and non-surgical. It is not either or, it is integration of all. And so many lessons that we learned about individualization of hormonal treatment, and also the effect or the importance of non-hormonal, non-surgical treatments that you utilize, and you try to tailor this to your patients, either from the anti-inflammatory, the COX-1, the COX-2, the hormonal treatments, the physiotherapy, nerve examination, neurolytics, and a lot to take, which is not only laparoscopy and surgical management. Guri, we really met the expert today. We learned a lot from you. And thank you very much for my colleagues from the EEL that supported this. And so many thanks for the colleagues who shared with us their experience and their questions. And I really would say that it was an excellent evening, and we had all learned and exchanged experience. Thank you all very, very much. Thank you, Aline, for the fantastic organization.
Thank you, everybody. Before closing this, please stay tuned. The next EEL webinar is going to be in October. So please let me share with you. Yes, so on the 8th of October, we'll be having Manuel Ianieri from Italy, from Olbia. He'll be giving a talk on parametrectomy for deep endometriosis, covering the topics of functional outcomes and complications. And Mikkel Sejer Hansen from Denmark is going to moderate the next EEL webinar. So we're looking forward to have you with us next month as well. November will be dedicated to pain. And December, I think we'll be going for anatomy. Mohamed, if I'm right.
Yes, you are. So we will be, yes, focusing on pain and, yes, surgery for the parametrium. And then next year, 2025, so many surprises. And we hope that you stay with us, and again, this is not, it is interactive, and every time we do a webinar, we learn from you as much as you learn from our speakers. Thank you very much.
Thank you, everybody, and have a nice evening. Thank you, Guri.
Thank you. Thank you, Guri. Thank you.